Today, we are diving into one of the most incredible stories in all of modern medicine. It's a journey deep inside the human heart, where surgeons don't just repair what's broken, they completely re-engineer the body's entire circulatory system to make the impossible, well, possible. It really all comes down to this one single question. And it's a pretty mind-bending one when you think about it. What happens when a baby is born with a heart that's basically missing one of its two main pumps? How can that heart possibly sustain a life? This is the huge challenge we're going to unpack. So the condition we're talking about is broadly known as a single ventricle heart. A common form of this is something called hypoplastic left heart syndrome. But in simple terms, what it means is the heart has only one working ventricle, and it's being forced to do the job of two. It has to pump blood to the lungs and the entire body. And without some kind of intervention, that's just not survivable. Now, here's the part that is just so amazing. The goal of these surgeries, it isn't a cure. They can't build a new ventricle. What they do instead is this audacious, brilliant replumbing of the entire system. They literally reroute everything to allow the child to live and grow with the unique heart they were born with. So, how on earth do they pull this off? Well, it's not one single operation. It's a meticulously planned three-stage surgical journey. Think of it as a roadmap for survival that unfolds over the first few years of a child's life. So here it is, the roadmap. It's broken down into three critical milestones, and each one is timed perfectly with the child's growth. It all starts with the Norwood, or Sano procedure, which is a massive emergency surgery that has to happen within the first few days of life. Then comes the Glen, around 3 to 6 months, once the baby is a little stronger. And finally, the Fontan, which is done somewhere between 1.5 and 5 years old. That's the one that completes the re-engineering. So let's break down what each stage actually does. Okay, so stage 1 is all about crisis management. Right out of the gate, the goal is just to stabilize the baby's circulation. The surgeons essentially combine the two major arteries leaving the heart into one single stable pipe. But in doing that, they create a whole new problem. How do you get blood to the lungs now? And not just any blood flow, but exactly the right amount. The answer is a shunt, a tiny artificial tube that acts as a new pathway. For a long time, the go-to was something called a BT shunt, connecting an artery that goes to the body with the artery that goes to the lungs. But there's a risk. See, the lungs are a very low-pressure system, so sometimes this shunt can steal too much blood away from the body, and that's really dangerous. That's why the more modern Sano shunt is often used now. It connects the ventricle directly to the pulmonary artery, giving surgeons a lot more control and helping to avoid that steal phenomenon. All right, so once the baby's a few months older, a lot stronger, it's time for stage 2, the Glen. The main goal here is to start taking the enormous load off that single, hardworking ventricle. What they do is pretty incredible. They take the big vein that brings all the blue, used-up blood from the upper body, the superior vena cava, and they just disconnect it from the heart and plug it directly into the pulmonary artery. So now all that blood flows straight to the lungs to get oxygen without even going through the heart. And then, finally, we get to stage 3, the Fontan. This is the one that completes the master plan. Now, the blood coming from the lower half of the body is also rerouted directly to the lungs. So at this point, that single ventricle has one and only one job: to pump fresh, red, oxygenated blood out to the entire body. The whole system of blue blood return now completely bypasses the heart's pump. It's a fully re-engineered circulation. Just amazing. To really wrap your head around how surgeons do all this, you gotta know the basics of their toolkit. Let's look at the 3 main building blocks they use to create these new circulatory systems. First up is the shunt. We've actually already met this one. Just think of it like a temporary bypass lane on a highway. You build it to get traffic around a problem spot. It's a tiny little tube, usually made of Gore-Tex, that lets blood flow between two places that aren't normally connected, just like in the Sano and BT procedures. Next up, the conduit. So, if a shunt is a little bypass lane, a conduit is like building a whole new exit ramp or a giant overpass. It's a much larger, more permanent pipe that's used to create a major new pathway for blood. It becomes a core part of the re-engineered circulatory highway. And finally, you have the baffle. Now, a baffle isn't a tube at all, it's a wall. It's a partition that surgeons build inside the heart's chambers to redirect blood flow, almost like putting a median strip down the middle of a highway to force cars into different lanes. And this clever trick of internal rerouting is the key to fixing a completely different kind of heart problem. So let's switch gears for a second and look at another condition called transposition of the great arteries.
This is where a baby is born with the body's two main pipes, the aorta and the pulmonary artery, totally swapped. Here, the problem isn't a missing ventricle, it's that the plumbing is all hooked up to the wrong places.
The way they learned to fix this is a fascinating story in itself. The original method, the atrial switch, used that baffle we just talked about. They'd build a wall inside the top chambers to reroute the blood. It was a really clever workaround. But it created a huge long-term problem. It forced the weaker right ventricle to do the lifelong, high-pressure job of pumping blood to the body, a job it just wasn't built for. And over time, that ventricle would often fail. So surgeons came up with a modern arterial switch, and this is so much bolder. They literally cut off the two main arteries, swap them back to where they're supposed to be, and painstakingly move the tiny coronary arteries right along with them.
And this is the whole point. While it's way harder to do surgically, the arterial switch is the standard today for one simple reason. It restores the heart's natural anatomy. It makes sure that the powerful muscular left ventricle is the one pumping blood to the body for life, which is exactly what it was designed to do.
But, and this is so important to understand, for all of these patients, whether they had a single ventricle or a corrected transposition, the surgery is just the beginning. It's really the start of a lifelong journey with a heart that is extraordinary, for sure, but also needs extraordinary care.
The reality is that this re-engineered system, as life-saving as it is, comes with its own unique challenges. You know, those artificial conduits and shunts, they can wear out over decades, which often means more surgeries are needed down the line. All that scar tissue can sometimes lead to irregular heartbeats, and the unique pressures created by the Fontan circulation can, in rare cases, lead to really serious complications like plastic bronchitis. It's a lifelong balancing act. And for some patients, after decades of incredible service, that replumbed heart just can't keep up anymore. In those cases, the final step in this long journey might be a heart transplant, which provides a whole new engine to power the system that was so brilliantly engineered all those years ago. Which really brings us back to the central idea, doesn't it? This whole story isn't about achieving perfection. It's about pure ingenuity. These procedures don't create a normal heart. What they do is brilliantly and courageously re-engineer the entire body to work in perfect harmony with the heart that's there, extending and enriching lives in a way that was once just unimaginable.
It's truly a testament to human creativity and resilience, and it just leaves you with this one last question to think about. After mastering the art of replumbing our most vital organ, what is the next frontier in